Yeah, I'm Yang Chen. I'm back to work. I just finished my family job. Yeah.
Okay.
Okay. So here's some questions for you. Okay. So first, drug-induced liver injury is estimated to be 14 to 19 cases per 100,000 persons. There are 3 types of drug-induced liver injury: direct hepatotoxicity, idiosyncratic hepatotoxicity, and indirect hepatotoxicity. What are the characteristics and differences among the 3 types of drug-induced liver injury? Okay.
Thank you very much for this very important questions. So first of all, I would like to thank you for giving the attention to this talk. So these 3 types, usually before last year, usually the DILI was divided into only 2 types: direct hepatotoxicity and idiosyncratic hepatotoxicity. But in a paper in the New England Journal of Medicine that was published in 2019, the 3rd type was introduced, at least in a publication, which is indirect hepatotoxicity. But if you go through these different types, the characteristics of the direct hepatotoxicity is that it's dose related. The higher the dose of the agent, such as acetaminophen or paracetamol, the higher the dose, the higher risk of liver injury. And the phenotype is characterized by acute hepatic necrosis in severe cases, and this is usually related to high exposure and high doses of the drug. And most people are familiar with acetaminophen, as it is called in the US, but paracetamol mostly in Europe. But other types of other drugs that are leading to direct hepatotoxicity is cancer chemotherapy of the old type, and intravenous methotrexate, which is used in some type of cancer therapy, for example, in children and in other conditions. And this can also be related to intravenous amiodarone, which is an antiarrhythmic drug, which is given intravenously. This can cause direct hepatotoxicity which is dose related, as I mentioned earlier. However, the idiosyncratic type is characterized by that it's rare. It's a rare adverse effect of a drug that leads to liver injury, where most people tolerate the drug in the same dose or the same duration. And this is, for example, this is not very much related to the dose, although recently it has been shown that this is not without a dose relationship. So for some drugs, the higher the dose, the more likely is it that they, although within the therapeutic range, that they can develop idiosyncratic injury, which is thought to be related to either metabolic or immunological reaction, and probably both in many cases. And this is the most common type of DILI, is this idiosyncratic dose. And for example, antibiotics such as amoxicillin clavulanic acid and other drugs like isoniazid used for tuberculosis. These are typical drugs that can lead to idiosyncratic drug-induced liver injury. And this is many other drugs, of course, are of this type. One of the most common biochemical and histological phenotype is a cholestatic hepatitis, which is quite common. But other types can without idiosyncratic type of reaction can be hepatocellular with dominant AST and ALT elevation, but also of a cholestatic, pure cholestatic reaction. So, for example, a good example is a bland cholestasis or a very cholestatic reaction related to the use of anabolic steroids. But so this is the common type. But this third type, which was introduced by J. Hufnagel at the National Institutes of Health, is the so-called indirect hepatotoxicity. And this is more caused by the action of the drug rather than its toxicity. And in the idiosyncratic type, the hypothesis is that a creation of reactive metabolites of the drug can trigger the immune system in a certain amount, and that can lead to either direct toxicity in this susceptible individual or immunological activation that can lead to injury. But this indirect hepatotoxicity is related mostly to what the drug does rather than what it is. In the case of idiosyncratic reaction, that it's leading to direct toxicity. And a good example is a infliximab induced hepatitis. It's not thought to be related to the toxicity of infliximab, which is not even metabolized within the liver, but it's related to the imbalance in the immune system that can also this can also be seen with the increasingly used checkpoint inhibitors, which is another part of this talk. And this can lead to imbalance in the immune system, which leads to dysregulation and by causing when the drug is interfering with the immune system, this can lead to autoimmune phenomena in different parts of the body and also within the liver. So it's to summarize the third part, it's an indirect action of the agent on the liver or the immune system that can lead to this reaction.
Okay, so the second question, with few exceptions, there are no specific diagnostic marker for drug-induced liver injury. The traditional serologic marker are ALT, AST, ALP, GGT, albumin, and TGF-beta1. New serum markers include PON1, miRNA, GLDH, GST, and so on. In your opinion, which one is the most promising marker in terms of sensitivity, specificity, and predictivity? What is the development of prospect of diagnostics markers?
This is a very good question, but it's a very difficult question, and I cannot state that I'm an expert in biomarkers, unfortunately, but this is obviously a very important question, and there is a big medical need to find a biological marker for DILI, because, as we know, we don't have a biological marker as for example, when patients are suspected of having hepatitis C, we can measure antibodies against hepatitis C in the patient, and also the virus itself in the blood with appropriate molecular diagnostic methods. But we lack a specific marker for DILI. So it is and the diagnosis of DILI could be said the Achilles heel of the study of drug-induced liver injury, as we rarely have a complete proof of the role of the drug, and relies on many other things, and of course our exclusion of other etiologies. So this has been intensively studied in recent years, and one of the studies that have tried to validate these biomarkers within DILI is in the so-called SAFE-T, which was an innovative medicines initiative, safer and faster evidence-based translation consortium in Europe, and there were several markers that were tested. Some of them mentioned here, for example, the microRNA, which you mentioned, and the spin-off of this so-called SAFE-T was the Trans-Bioline consortium, which is ongoing, and Trans-Bioline stands for Translational Safety Biomarker Pipeline, and where this is a consortium dealing with many different drugs and many different adverse effects, also analyzing kidney injury and vascular injury and central nervous system injury. But in terms of the drug-induced liver injury, collection of cases which is ongoing is evaluating these new biomarkers, and these are measured in patients with suspected DILI, as a mechanistic assessment for the severity of the reaction, and also for early diagnosis, and obviously it's a big medical need, and it would be very appropriate if we could have a marker that in some way can distinguish DILI from other causes of acute liver injury. And actually within this TransBioline study, within the DILI part of the TransBioline, which is within Europe, it's called the Prospective European DILI Registry, Pro-Euro-DILI. Cases are recruited, and the biomarkers that are used in this study are for the purpose, as I mentioned. Some of those patients who are suspected of DILI, they turn out to have other diagnosis when patients are undergoing many different tests. So those who look like DILI do sometimes have another diagnosis, such as viral hepatitis or autoimmune hepatitis or other causes of injury. And those cases who are recruited, who turn out to have an alternative diagnosis, they're used as a control group, control population. So this is valuable because it would be, and one of the hypotheses is that some of these biomarkers can be used for early diagnosis, and hopefully they can be used as to distinguish between DILI itself and other diagnoses that come from this project. So for mechanistic assessment, a biomarker for mechanistic assessment, and early diagnosis, and also for a biomarker that can predict the course of the reaction, the prognosis. Because some patients who develop DILI, particularly those who develop jaundice, they can develop acute liver failure and either die from liver failure or need a liver transplantation. But so far, I don't think we have very good evidence that these markers are better than the others. But this has been tested also in other etiology, for example, microRNA. But I cannot say which are the most promising markers. But this is I think we have to wait for the results of this TransBioline effort.
Okay. The last question: if there is a drug-induced liver injury treatment investigation, new drugs approved for clinical trials, the population are all liver injury patients. We know that all the new drugs have the probability of liver injury. So how to balance the benefits and the risks in trials? How to reduce the risk of liver function deterioration in the trials?
Thank you for this important question. This is one of the goals of the future, is to try to do a proper clinical therapeutic trial that can alter the natural history of patients with drug-induced liver injury. This will be only for a specific part of those with DILI, because most those who have mild and moderate DILI, they don't require any treatment at all, because they will normalize when they will recover when the implicated agent is discontinued, when the drug is taken away, they will improve. But a certain group of DILI, for example, we can mention patients with anti-tuberculosis regimens. They can die of liver failure. So in these patients, and also other patients with DILI that is severe, there is a medical need to try to develop a therapeutic strategy that can save these patients. But I think this is a very, very good and important question, because we don't want to further worsen this liver injury by giving them another potentially hepatotoxic drug. But I don't really agree completely with this question that all new drugs have the probability of liver injury. I think when you look at drugs that are on the market, only for example, drugs that are registered in the United States, only approximately 50% of these drugs, when they have been scrutinized, have a potential of leading to DILI. And this has been shown in a study that was published some years ago, when these drugs have been categorized, drugs that were a part of the liver tox. And I think, for example, a drug that was given in a study in the US, N-acetylcysteine, which is used as or registered for treatment of acetaminophen-induced liver injury. I think that's a good example of a drug that can be therapeutic, and it can have therapeutic advances even also in a non-acetaminophen-induced liver injury, and and that has been shown in early phases. So so we are not. I'm quite sure that not all drugs on the market have the probability of liver injury, but of course the problem is that if we have a new drug, so I would guess that at the current time there is not a very good documentation that apart from this exception of N-acetylcysteine or NAC that has shown benefit in a clinical trial, the other therapeutic agents that have been used for prevention and treatment of DILI have not shown convincingly to have effect on DILI. So if people would like to do a therapeutic trial in DILI, I think placebo would be the comparator to an intervention, and it is complicated to design a therapeutic trial in DILI, and it's conceivable that at least in some patients that N-acetylcysteine would be would be the drug that could be tried to as a treatment for advanced DILI, but this design and endpoints need to be really analyzed before we can decide on a treatment for DILI. But obviously, I agree completely with that people should be very cautious when starting a treatment of an adverse effect of a drug with another drug. So this is my. So, but I think we need to, within the scientific community and within the medical field, we need to come up with some therapeutic strategy in patients with very advanced DILI, because at this moment we don't have any other means other than liver transplantation, which cannot be which not all patients can achieve, unfortunately.
Okay, thank you to talk with me. And after our interview, I will write down our talking, and we will edit the article, and we will publish it on our website, and I will email to you. Okay.
So,
yeah.
Do you need a photograph?
If you have,
or
you can email to me.
Yes, I can do that. Yeah.
Okay, thank you.
So, are you in Beijing?
Yeah, I'm living in Beijing. So there is a time for 7:30. Okay.
In the evening.
Yeah, evening. Yeah.
Yes. Okay. So I was in Beijing 2 years ago with visiting. Very nice with.